First of all, the introduction. Neck space infections can be superficial or deep. Deep neck space infection is defined as the infection in the deep facial plane enclosing the potential spaces of the neck, which are classified as those located above the hyoid bone, which may be peritonsillar, mandibular, parapharyngeal, masticator, temporal, buccal, and parotid spaces. Those located below the hyoid bone are anterior visceral space. Those involving the entire length can be carotid, retropharyngeal, danger space, and prevertebral spaces. Whereas superficial are those in the superficial spaces. The aim of my study is to determine the etiology, clinical presentation, cause, management done in patients with neck space infections. The objective is to describe the etiology most commonly involved in the neck space infection, to determine the factors affecting the progression of the infection, to analyze the emergency cases and the required surgical intervention. Methodologies. A total of 10 cases were studied retrospectively in 3 months duration, which included the detailed clinical history, etiology, what was the causative factor, or what was the basic root cause that caused to this infection or abscess. Then immediate management done in these cases. The culture sensitivity reports were traced and the final management that was done. Now the risk factors. Mostly it is seen that neck space infections are more common in male, but in our study it was seen that females were at more risk. Recurrent tonsillitis, active smoking, then poor oral hygiene or dental caries, intravenous drug use, then immunocompromised state such as long-term steroid use, or in immunocompromised conditions such as HIV, then type 2 diabetes mellitus. Clinical presentation. Patients mainly presented with complaints of fever, odynophagia, dysphagia, difficulty chewing, neck swellings, throat pain, and neck pain. Patient often presented with emergencies such as difficulty breathing, noisy breathing, and in case respiratory distress also. Neck space infection mainly present as emergencies only in our tertiary care center. This is a chart showing the common abscess that we found, of which peritonsillar abscess and parotid space abscess was more common. The clinical presentations in our cases, the first image shows a peritonsillar abscess. This is a female, middle-aged female, presented with cold abscess. This is a 1-year-old male child presented with right parotid space infection. This is a patient showing first patient had superficial infection. Later on, it got necrosed and patient presented as late. This is a case showing submandibular abscess. This again a female child showing left parotid space abscess. This was a case of middle-aged female showing necrotizing fasciitis. Patient had long-term history of neck space infection. Swelling was present, but she presented as late. So we were assuming that patient had Ludwig's angina, but it was neglected and she presented to us with necrotizing fasciitis. Then the management part. Emergency incision and drainage was management of choice in cases of Ludwig's angina, submandibular abscess, peritonsillar abscess, followed by IV antibiotics. Whereas other abscesses were managed by giving IV antibiotics according to the culture sensitivity from aspiration of pus from the abscess. Some patients also require suturing of incision and drainage wound for secondary healing. The results. Out of 10 patients studied, male is to female ratio was 2:8. After tracing of the culture sensitivity report, it was found that deep neck space infections are usually polymicrobial, with Streptococcus, Staphylococcus aureus, and anaerobes being the most common causative organisms. Most common organism here in our study was Streptococcus pyogenes, followed by Staphylococcus species. Anaerobic bacteria are usually the causative organisms in cases of infections where the cause was mainly dental, whereas Streptococcus usually the causative organism in infections of pharyngotonsillar origin. Staphylococcus aureus is highly prevalent in deep neck space infections in children, whereas Klebsiella pneumoniae is more commonly seen in diabetic patients. The conclusion. Cervical lymphadenitis is most common cause of deep neck space infections in children, whereas infection suppurates in the retropharyngeal or parapharyngeal lymph nodes. The most common cause in adults is tonsillar or those arising from the dental pathology. Then neck space infections commonly present as emergencies due to lack of information and negligence by the patients and their relatives. Submandibular space was the most frequent location for a single space abscess, followed by tonsillar abscesses. My references.
Okay. In causes, you mentioned about superficial and DNI, deep neck inspection. So in how many cases you got dental caries as a cause of your abscess?
Out
of 10?
Out of 10, in 4 patients, there were dental caries were present. And as a line of management, we had also done dental extraction of these patients.
Okay. In Ludwig's angina, in how many cases you got aspiration of pus or you get pus after aspiration or incision drainage? And is it essential to get pus always in Ludwig's angina?
No, actually, it's not essential. But in one case only, we got aspiration of pus. Thank you, sir.
Number and the percentage that you mentioned, I think it's wrong. Can you go back to the slides of yours?
Yes, sir.
If you said there are 10 patients, then how come the 23% patient has got peritonsillar abscess? How come 11% patient has got? Either it has to be 20%, 10% or something.
No.
So I think that is the one thing. Or is it some mixed infection in some patients? That's why you have calculated that. So clarification needed regarding that. Because the number of data that you collected and the percentage doesn't match.
Sir, actually, it was at 10 cases. That's why the number percentage comes.
So how 2.3%, 2.3 patients got peritonsillar abscess? Either it has given 2 or other 3 patients.
I hope you got his point. You, in 10 cases, you cannot say like 2.3. Huh? So either it should be 10, 20
sir,
like that.
Total out of 10 patients, 2 patients were there of peritonsillar abscess and 2 patients were there of Ludwig's angina patient.
Then it has to be a 4. It has to be 40%. It cannot be 23%, 11%. Because that completely changes the outcome of this. Because what you suggested is the peritonsillar abscess is most common in deep neck space inspection. Literature suggests it doesn't like that. This is one point. And second is, you said that the treatment of choice is an incision and drainage. But for a necrotizing fasciitis, what is the treatment? Because the patient presenting late with a gangrenous skin, you cannot have an incision and drainage.
Sir, actually for the patient, we had done debridement.
So that has to be written.
Okay, sir.
It cannot be understood by any of us. It has to be specifically mentioned that the debridement and the thorough repeated debridements and these things has to be.
Yes, sir. Actually, the patient, throughout the course of management, we had done the debridement and then we had transferred the patient to a plastic surgeon for a graft.
That's correct. I understood. But that has not been mentioned in your paper. You written as it's only the incision and drainage followed by the IV antibiotics.
In short, data should be more, not like, because you cannot conclude in 10 patients. That is what you want to see. Huh? Okay, nice. It's a good attempt. Thank you.